we going to find enough doctors to treat all these patients with diabetes? I think that's a reasonable question. So maybe Ann and Bill, the good news is you can stop saving for your retirement because you'll be working. Speaking of ruining people's retirement, the other thing that's going to happen is that there's going to be a huge impact on Medicare. Okay, so currently, spending on patients with diabetes is around, it's still significant. It's about, say, 1/3 of total Medicare spending. By the time we get out to 2050, about 1/2 of Medicare spending will be generated by patients with diabetes. So not only is the prevalence rising in the population, but the magnitude, the importance of the disease within public health insurance programs is also rising. We don't have numbers for Medicaid, but I imagine the story might be potentially even worse within Medicaid, as rates of diabetes tend to be higher within the Medicaid population. So given these basic facts that diabetes is a growing problem, and of course it's probably not a secret as to why it's a growing problem. Trends in obesity are at least partly responsible for increases in diabetes, perhaps even largely responsible. And there's no evidence so far that those trends are slowing down. Okay, so if you look at what's going to happen in the future, along with population aging, diabetes is going to become ever more significant. Now, that's kind of the aggregate view. From the patient's viewpoint, it's also, of course, quite costly. If you look at, for instance, at the onset of diabetes, let's say, just to take an example, the age of 51, what does it do to a patient's lifetime health outlook? Well, you can see, first of all, it lowers life expectancy on average by almost 4 years. It lowers healthy life expectancy, so the number of years you can expect to spend without disability, by over almost 6 years. Okay? And it increases your healthcare spending by something on the order of about 25% or so. So the question now we might ask is, clearly it's very costly to patients, it's very costly in aggregate, and it's going to become increasingly costly. And what are the kinds of interventions that can mitigate these consequences for patients? Now, clearly it's well understood and documented that biomedical innovation is helpful for patients with diabetes. But the question that we were interested in was, I think, one that hasn't been asked as often, which is, what complementary role can be played by technologies that help us make better use of the medications that already exist? Okay, so and we think about two specific examples here. One is technologies that can help improve adherence to medication, and second of all, technologies that can help make insulin more tolerable, or the initiation of insulin more widespread. So these are both kind of forms of adherence, ways of helping patients cope with the demands of taking medication, initiating medication. And what we wanted to do was model the effects of improvements in adherence, improvements in insulin initiation, and compare those to, as a benchmark, to other kinds of scenarios in which the efficacy of prescription drugs improves due to standard biomedical innovation. And it gives us a little sense of what role can adherence interventions, for example, or investments in new technologies that promote adherence, what role can that play in the ecosystem of care for diabetes patients? So here's what we did. What we used was a model called the Future Elderly Model. I'll say a few words about it. I won't, in the interest of time, I won't go into deep detail. But the Future Elderly Model has been around. We've been developing it for, I guess, almost 15 years now, more than 15 years. It's a simulation model that essentially models how Americans age, grow old, get sick, acquire disabilities, and die, and what their health status and health spending trajectories look like along the way. And so it can help you understand what are the consequences of the introduction of different kinds of technologies, interventions, disease states, and health trends. It's based on a very interesting and important longitudinal database called the Health and Retirement Study, which is a nationally representative survey of Americans over the age of 51. It has about 10,000 people in it who have been followed biennially since 1992, so you have quite a long time series over which to follow these patients. In 2003, of particular interest, the HRS fielded a special diabetes supplement to a subset of respondents that had diabetes. And that supplement collected a lot of valuable lab values, such as HbA1c status. It also collected a variety of information about adherence to diabetes medications and information on insulin initiation. And what we wanted to do was to quantify the gross value to society of new technologies and approaches that would improve adherence, of new technologies and approaches that would enable the increase in insulin initiation, and compare that ultimately to technologies that just improve the efficacy of drugs. So at a very high level, the way the future elderly model works is in a sequential fashion. So think of patients that have a certain profile of health characteristics and demographic characteristics and hemoglobin A1c. So those patients receive some treatments that depends on what treatments are available at the time, depends on their access to treatments. And the effect of those treatments it depends on two things. One, the kind of raw efficacy that you might find in a clinical trial, estimated in a clinical trial. And then also it depends on the patient's adherence to those medications, because typically adherence and efficacy are complementary. So if you adhere better to drugs, you'll get more of the kind of full efficacy benefits, and vice versa. If you adhere less, you'll get less of that efficacy benefit. And then the treatment translates into a variety of outcomes for these patients. Their economic outcomes like spending, and their clinical outcomes like your life expectancy, your disability, your comorbidities, and such. So in terms of the way the model works over time, think of a simple example where we start out, let's say we start out with data from the 2004 Health and Retirement Study. And the first thing we do is we figure out what people in that study what kinds of health technologies they're using, what medical services, what drugs they're using. And that tells us how much they end up spending on drugs, what their clinical status is, and it also tells us what's going to happen to them. So, for example, suppose you think of a 54-year-old male patient with diabetes and hypertension, and that male patient is on a certain set of drugs. That patient then has a risk for developing disability, has a risk for dying, and that patient can then be aged forward over time using those estimated risks that are estimated from real-world occurrence of these conditions in the HRS itself. And you move forward in time in that fashion. You age people forward based on what drugs they're using and based on their health status. And over time, they acquire diseases, they acquire disability, and some of them might die. Eventually, of course, we simulate all of them, all of their entire life expectancy. Then diabetes is laid on top of this model. So think about somebody who's diagnosed with diabetes in 2004. Okay, so at that time, based on what we see in the data, that person gets assigned an HbA1c level. So for example, the data will tell you what fraction of newly diagnosed diabetics have A1c between, let's say, 9 and 10. Okay, so that allows you to assign an A1c value to newly diagnosed patients with diabetes. Once that assignment is made, patients initiate medication, and then they are allowed to change medication, add new medication, switch over time. So this is the way the model kind of generally operates, and I should mention that the study was published in the AJMC, so you can look at some of the details, but I'll just leave it at that and leave out a lot of the specifics and get to kind of the meat of the issue. One important point to make here is that the estimates of drug efficacy come from a set of published studies. The AHRQ has a comparative effectiveness review of efficacy that we used, and the long-term follow-up data from the UK PDS provided other information that we also used. So based on this, we were able to talk about the value of improvements in adherence and improvements in insulin initiation. So what we did was we simulated how a cohort of 51-year-old patients moved forward in time under 3 different scenarios. One is a status quo scenario where everything stays the same. The other is imagine we wanted to calculate the value of eliminating poor adherence. So this is essentially the overall value there is in society from technologies that could improve adherence. And then finally, imagine that we were to double the rate of insulin initiation among these early 50-year-old patients. So we want to compare these three scenarios and understand how they fit together. So a couple of facts that came out of that exercise. One is that you do, not surprisingly, by improving adherence and getting people more tolerable versions of insulin, you can increase life expectancy. Adherence is valuable because it improves the efficacy of drugs. Insulin initiation, at least in this age range, can also be valuable, but it's well known that patients aren't always so able to tolerate it or interested in being on insulin for a variety of reasons. So think about the value that would be created if we could address some of those issues. And it turns out that the additional life expectancy that you could provide to patients with these kinds of scenarios is on the ballpark of around $15,000 to $18,000. That's significant even after you net out the increase in medical spending that occurs because people are living longer, it's still a significant gain in value. That's not so surprising. I think the key question we have is, how does this compare with other benchmarks of value and investment in society? And here, let's go through some of the per capita and aggregate values. So to each patient, these scenarios are worth about $14,000 to $15,000. And on aggregate, to this one single cohort of 51-year-olds approximately, it's worth about $10 billion or so. These are big numbers, but what do they really mean? Well, one way of thinking about it is that these numbers are on par with a 5 to 6% increase in the efficacy of all non-insulin medications treating diabetes. Okay, so 5 to 6%, think about this as improving the efficacy of drugs taken by all patients by 5 to 6%. That's kind of a big number because let's say, for example, you have a new drug launch that, let's say, 20% of patients use. Okay? In order for that drug launch to increase average efficacy by 5 or 6%, that has to improve outcomes by about 25 to 30% for the patients who are actually using the drug. That's a really successful, important drug launch. And looking at the recent history of drug launches in diabetes, that would very likely take multiple drug launches, okay, costing, and we know that each drug launch costs about $1 billion to society. So to a rough approximation, investments of a couple of $1 billion are very reasonable given the value that's being created from improved adherence and improved insulin initiation. So what does this mean in terms of policy implications? So as we've seen, the prevalence of diabetes is skyrocketing. Okay, so by 2050, we'll have 1/3 of Americans in this age group will have type 2 diabetes, and they will suffer a variety of negative health consequences. We certainly know what role biomedical innovation can play, but there are other types of investments that we ought to consider promoting and making as a society. Investments in improved adherence could be worth, for example, almost, say, $13,000 per patient with diabetes. Investments in figuring out how to make insulin more tolerable could be worth approximately a similar amount. And with millions of patients expected to contract diabetes over the coming decades, the value could become quite substantial indeed in the aggregate and can certainly justify the kinds of innovation investments that we've typically only allocated to biomedical innovation. Maybe we ought to be thinking more broadly about how to produce new processes of care, new techniques for improving adherence, affecting behavior, and the like, which traditionally has been kind of given a secondary kind of status when we think about innovation investments. Now, there are a lot of questions that remain to be answered here. For example, in terms of insulin initiation, I mean, there was actually quite a good, this has bearing on the discussion that Ann gave this morning on the position statement. What kinds of patients would benefit most often from earlier insulin initiation? When should they get it? What barriers exist? What kinds of behaviors and cognitive problems are associated with taking insulin? In terms of adherence, how do different kinds of adherence interventions affect different kinds of patients? It's very likely that a given adherence intervention won't benefit everybody, that you have to target them very specifically to certain kinds of patients. And what is the effect of particular interventions on particular kinds of patients? All of these questions remain to be answered, but the point here is that significant investments are warranted in arriving at these new kinds of technologies. From a policy perspective, I think the implication is that policy and payment ought to begin to encourage more than just biomedical innovation. It should also encourage interventions that improve patient behavior and compliance and get more out of existing drugs. Now, present company excluded, some payers have been reluctant to reimburse technologies that focus specifically on adherence and convenience and those kinds of outcomes. That's changing with the implementation of the ACA and other kinds of policies in which payers are taking a more holistic role in care, and those changes I think are to be encouraged. That over time, health policy should encourage incentives to come up with new technologies that help us make better use of existing therapies through improving adherence and initiation of medication. Okay, so thanks very much for your attention, and Josh.